Hello, I'm State Representative for Price. It's a privilege for me to join you all today, albeit virtually. I wish I could do it in person, but I want to welcome you to this TD Talks event and really thank you for your participation. The last several years in Texas have been really fantastic in terms of moving the needle on erasing the stigma with regard to mental health, raising awareness with regard to treatment options, creating opportunities for treatment, talking about how to handle mental health in our communities, providing additional resources and grant options statewide. I'm really proud of that. I'm proud that a couple of sessions ago, we also created a TD or Tardive Dyskinesia Awareness Week in Texas. So it's very timely that you all are participating in this event. It's timely that it's starting off in May, which is Mental Health Awareness Month. And I'm just thankful for your engagement, your advocacy, and your interest. It really makes a difference. And through your engagement, not just today, but just generally, policymakers and advocates have really done great things in the state, and I'm encouraged by that. So thank you again for your participation. Enjoy the event, and we'll see you soon.
Hello, I'm here with Dr. Stephen Saklad. Dr. Saklad, you've had a long and distinguished career in clinical care, psychiatric pharmacy, and academia. I'd like to ask you, what drew you to the field of mental health?
I'd always been interested in people. Even in high school, I was the person people used to go to talk to about all kinds of problems they were having and discussing, and we'd problem solve it and try and figure out what an approach would be that they could achieve what they were trying to.
That's very interesting, and I really appreciate your service in this field. There is a great shortage of mental health care professionals, so we need more people like you to come forward and serve in the capacities that you've served in. I want to thank you also for your willingness to be interviewed for NAMI Texas's Texas TD Talks video series. I saw by reading your bio that you've spent decades working in clinical care, providing psychiatric pharmacy services. I'd like to ask you to give us a little historical perspective on how tardive dyskinesia has come into play for your patients over the years. And what was understanding of TD and treatment of TD like in the early stages of your career?
That's a very interesting question for me in particular. My actual position at the state hospital in San Antonio was created from funds that were created because of a lawsuit settlement between the state of Texas and the United States government. The state of Texas was found negligent on providing adequate monitoring for tardive dyskinesia and created an entire monitoring system. Part of that was money that was used to hire me. The history I've had with tardive dyskinesia was a chronic problem. We saw it all the time, every day. We had patients with tardive dyskinesia. We ran a number of studies trying a whole bunch of interventions in the early 1980s, trying to find anything that would treat tardive dyskinesia. So I've had a long history with that. A few years later, we were working on clozapine that caused much less tardive dyskinesia. And then that really led to all of the second generation drugs, which we did much of the research at San Antonio State Hospital's research unit. And that allowed us to get these newer medications that have a much lower rate of tardive dyskinesia. Not zero, it's about 7%, but as opposed to about 30% from the older drugs.
So before a person gets access to the appropriate treatment, and we'll talk about what tardive dyskinesia treatment looks like in modern times, but before a person gets access, how would you characterize their typical life experience living with TD? What kind of impact can it have on their life?
Depending on the patient, they may or may not be aware of the problem. We used to use the antipsychotics somewhat willy-nilly. And a lot of people got exposed. A lot of people got fairly high doses. And those people had fairly severe movement disorders that were noticeable from quite a distance. I could pick patients out of mine from across a shopping mall because their movements were so obvious. I have friends of the family that have had tardive dyskinesia, and that at like a dinner, you can see that they are having movements and are grimacing. These are very distressing to everybody at the table and distressing to the person that has it. So you have the patient impacted, you have the patient's caregivers and family impacted, and you have the relationships with that patient with everyone else that's impacted. This is a very distressing disorder.
So if a person gets access to our TD awareness campaign materials, or finds out, about TD, and they come to believe that they or their loved one may have TD, what advice would you give them as a psychiatric pharmacist?
Well, the first thing to do is to make sure that you get a good evaluation. So that means going to see your psychiatrist, a neurologist, or your primary care physician if they're knowledgeable about tardive dyskinesia and mental health issues. A good evaluation is sometimes very difficult. There are movement disorder specialists who will disagree about the details about tardive dyskinesia, whether this is or not, whether it might be Parkinsonism or both. So there's a lot of nuances here. This is not very clear cut. Screening, however, for it can be done with an AIMS exam, which is, for example, all of my students at the University of Texas College of Pharmacy are all trained early on in their career for doing this abnormal involuntary movement screen. They can do the screen. If that's positive, they can then refer you to somebody for an expert diagnosis and then put you on one of the appropriate treatments that's extremely effective at reducing the symptoms.
That's great to hear that people have options if they come to believe they or their loved one are impacted. There are healthcare providers that are educated on TD and that know what to do, know how to screen, know how to assess, and know how to treat.
Right.
And I know that hasn't always been the case. We've come a long way in identification.
I'd like to point out that a lot of clinicians really don't understand this well. So if you don't get the answer you want, a second opinion is always a good idea.
Yes, absolutely. So you've been an active leader in the College of Psychiatric and Neurologic Pharmacists since its inception. That's CPNP. Can you tell us about the efforts that CPNP is making or has made to address TD?
We've had a number of initiatives over a long period of time. We've had programming on tardive dyskinesia for many years now. The Texas version of that meeting, which actually was the one where it started, is the University of Texas's Psychiatric Pharmacy Update, which we'll be having our 34th meeting coming up in this fall. And we have had like evening workshops before that meeting started, and these help train people at doing the exams. So we've been doing a number of things to try and improve things. There's a video series on the CPNP website for training people to learn how to do this. There are background lectures. There's a DVD that can be purchased for training people at facilities. So CPNP has been working on this for a number of years, trying to really bring this to people's attention.
Yeah, and that kind of leads me to my next question. Of course, for people, pharmacists who are connected to CPNP, they're getting exposure to this, information. They're educated on TD. Across, more broadly across the mental health and primary care provider community, how would you assess, knowledge of TD? Is it, your belief that TD curriculum is being taught in the right places?
It is not universal yet. Actually, on Friday this week, I'm doing a pharmacotherapeutics lecture for my third-year pharmacy students on tardive dyskinesia and the related disorder of Huntington's chorea. And they're getting a whole lecture on that. These are all disorders that are not really well taught in most pharmacy, medicine, nursing programs. They are relatively weakly taught, and the people that have been out for a number of years have not experienced the training that they needed. There are some that are very, very on top of it, and there are many that need additional training. So it's very scattershot.
Mm-hmm. Yeah. Well, hopefully there will be an evolution there, and
It's
all
changing.
healthcare providers, because it seems to me like the initial identification of TD may occur not necessarily from a mental health specific provider. It may be a primary care provider. I mean, it may be a mental health peer provider, someone with lived experience, and it may even be a family. It will likely be a family member who
It's very likely to be the family member.
Yeah.
The family member will notice it and say, why are you doing that? And they'll say, I don't know. I'm just a habit I picked up. One of my patients explained their chewing motions by developing a habit of chewing gum. But when they took the gum out, they still chewed.
Mm-hmm. Yeah.
One of the things that's different, just to point out one of the nuances, when you're chewing, your mouth is going up and down, but the movements of tardive dyskinesia are frequently lateral jaw movements.
Yeah.
That's not a normal part of chewing.
Right. Yeah. It's little things like those that, if people are educated on them, they can play a big role in helping people get access to the right treatment. And I
Absolutely.
think, for family and peer oriented mental health organizations like NAMI Texas, we have a responsibility to be providing education and content related to TD, because we are really on the front lines of interacting, with people who have TD.
Right.
And so that, getting close to wrapping up here, I do want us to make sure we touch upon, the contemporary TD treatments. What do they look like, and, are people getting access to them?
There are really three of this new category of medication that are available. Two of them actually have an indication for tardive dyskinesia, and these are called VMAT2 inhibitors. The letters are all complicated and just very long words, but basically this is a way of adjusting the neurotransmitters that are causing the abnormal movements in a way that reduces them and keeps them in abeyance. The studies have very effectively shown that these are relatively rapidly effective, and in fact, for chronic use, the effect almost doubles over a year or two. So it's very effective medications. They're unfortunately quite expensive. There are most insurance programs will cover them. Medicaid covers it. When you look at people who are indigent in some way, are unable to pay for it, don't have insurance, not quite the same thing as indigent, I guess.
Mm-hmm.
Those who have trouble, there are patient assistance programs that the two companies that have approval will provide medications. They'll provide starter kits to see if it's working, and they'll provide assistance on getting the medication. Sometimes they'll even pay for the copay that the insurance company would make you pay for the medication.
Well, that is great to hear. One, that insurance companies do tend to be paying for the medication. On the Medicaid side, I know you've been a voice in conversations relating to the Medicaid system. NAMI Texas has actively encouraged the state to make sure that these medications are available in Medicaid. On the uninsured front, at least there are some patient assistance programs that are out there, and we'll make sure we're promoting those programs in our communications related to TD. So thank you for spotlighting those.
Yes.
Last question, just for anyone who may be watching or listening to this interview during TD Awareness Week, which is the first week in May, or at any time, if they're an individual or family member affected by mental illness and or TD, what bottom line message would you have about TD for anyone who may be watching?
Don't despair. There is effective treatments. You need a good evaluation, and we are likely to be able to decrease the movements at least a little in virtually everyone, and a tremendous amount to make them go away in a few. So there's a lot of hope. We're doing a lot of work on how these medications work, on the mechanisms of tardive dyskinesia itself, and there is going to be better treatments as time goes on, as we learn more and more. But right now, there are highly effective treatments. Just get evaluated and get started.
Thank you for that. I think that's really powerful. You know, we want to encourage everyone to not despair. There is hope, and there is help available. So please reach out if you feel that you may be impacted. If you're watching this video, we can help point you in the right direction. And with that, thank you, Dr. Saklad, for doing this interview. We really appreciate it.
Thank you for inviting me.
Welcome back to our Texas TD Talks interview series. Thank you for being here. I'm here with Athena. Hi, Athena. I want to thank you for doing this interview. So I understand you're an employee of a NAMI organization. Can you tell me a little bit about what drew you to the field of mental health?
Well, I think it started way back when I took my recovery seriously. And I was in search of anything and everything that could potentially help me develop a safety net underneath me. And NAMI was the predominant piece. And I became part of Connections. And then fast forward through just, up and down and sideways with my conditions, I managed to settle down enough to be able to start volunteering for NAMI Colorado in a few years ago. And next thing I know, Mr. Ray Merenstein, my wonderful executive director, promoted me to finance director after I was doing the books for a few years. So I became very dedicated to helping NAMI in general and the mission, as not just on a state level, but on a national level. And I too am a very big advocate, and I'm here to pay it forward. And that's why, and that's how I got involved.
Thank you. Thank you for sharing that. It's really cool to hear how you found a way to channel your personal experience and your personal story into something that is in service of others. That's a really wonderful thing. I think that's what brings a lot of people to the work that NAMI does across the country and more broadly to the field of mental health. So I'm looking forward to learning more about you. We've just met. I don't really know your story. I don't know much about your background as an individual or with mental health. So I think myself and our audience would like to hear a little more about that. One thing that's cool in hearing that you're from NAMI Colorado, we're doing a world premiere of our Texas TD Talks video series next week in Amarillo, Texas. And geographically, I think you may actually be closer to Amarillo, Texas there in Denver than I am to Amarillo all the way down here in Austin. So
I'll have to check the map out for sure.
yeah. Hopefully you can join us in Amarillo.
Yeah, there you go.
So going back to Texas TD Talks, can you tell me a little bit about when you first learned about tardive dyskinesia and talk about how it's impacted your life?
Well, I'd have to go back to the 90s. I'm aging myself a little bit. I actually was a pharmaceutical sales representative for a very prestigious pharmaceutical company that had just released one of the biggest antipsychotics for bipolar disorder, which they had started calling it bipolar disorder prior to manic depression. And interestingly enough, here I had learned all that you can think of about this particular drug. And less than a year later, after some incidences occurred in my life that traumatized me, I developed a form of disassociation that developed into bipolar disorder and funneled through complex PTSD. And I was in such denial, Greg, really, about my condition that I wasn't paying mind to anything else, really. I was just trying to get off the drugs because at the time back then, bipolar disorder was, a hot topic. Everyone was getting diagnosed. Famous people were coming out of the woodwork, things like that. And it became very hyped. And I was in denial that there's no way that I got the most popular diagnosis. So anyway, with TD, what happened for me was because of the level of meds that they had me on, I started developing almost like I felt like I was getting frozen. My body slowly started like the Tin Man, without oil. My body started responding to the meds in a way that I couldn't control. I couldn't speak. I still have challenges with my tongue. I have severe TMJ that developed into severe TMJ because of the twitching and the automatic movements. The part that really made me heighten to TD and wanting to understand how could I stay compliant and accept the fact that TD may be part of my life for the rest of my life, and that I would have to take medication for it. So that's basically what happened for me.
Yeah, wow. Well, again, thank you. Thank you for sharing that. I can only imagine how difficult that was to develop such severe symptoms. And, it's something, as it turns out, it affects many, many thousands of people across the country. And I'm sure for everyone, it's, in many cases, the symptoms are similar, but the impact on their quality of life can be different depending on their circumstances. So I'm curious, how did those symptoms play out in your life? What sort of disruptions did that present in your life when you developed those symptoms?
Well, because I happen to have bipolar 1, which psychotic features, I would have a severe fallout, Greg, afterwards, after an episode. I've had 16 hospitalizations total due to non-compliance, TD, primarily TD, because it was affecting my ability to move forward with my life and my relationships, both professionally and personally. The most poignant moment was when I would attempt to, I don't know if poignant's the right word, I'm trying to be poetic here, but no, really, it actually was when I was trying to interview for jobs, and my hands, I could not, no matter what I did, and it went from shaking to clenching, and they didn't know what was wrong. And nope, I didn't come out and disclose, oh, by the way, I happen to have a dual diagnosis. Not nowadays where everybody's vocalizing mental health and we're finally being heard. But back in the day, when I would try to interview, I'd come home devastated. And my mother said she just couldn't bear it. It was just so hard after each episode to try to piece my life back together, develop intimate relationships, develop professional. So if that hopefully answers your question, how profoundly it would impact my ability to move forward.
Absolutely. Yeah. And that, I will say, is something that I've heard before, that the symptoms of TD can cause a person to feel ostracized and uncomfortable when seeking out professional opportunities. It can make it hard to get a job. it can make it hard to hold down a job. You know, one, because I think it can impact people's sense of self-confidence. It can make people feel like they're under the microscope. And then on top of that, there is the reality that, you know, people out in the world don't necessarily even know what TD is. If they do know what TD is, they don't know that someone might have it and that they're having involuntary movements as a result of it. So there's a lack of understanding about what TD looks like, what it is, and you know, I think as a result of that, that causes, you know, people with symptoms oftentimes to miss out on opportunities in the world, and that's a sad reality. So I think part of our challenge is furthering understanding of TD, and then secondly, furthering acceptance of people with TD, and then, you know, to close it out, making people understand that help is available, you know, that there is treatment and that it works. And I'm thinking, you know, in your case, like when TD presented itself in your life, there weren't, you know, these very targeted treatments for TD. I'd like to ask you about that, but first, I wanted to ask you about your journey with bipolar disorder and complex PTSD. So I think you had said, you know, you developed TD as a result of mental health medications that you were taking. And once you realized that those medications were causing TD, you drifted away from taking mental health medications that you had been on. So, you know, at this point in your life, like, things seem to be going well right now. Like, you know, you have this wonderful job with a NAMI organization. So what got you from that point where you had stopped taking mental health medications because they were causing TD to where you are today?
Wow, that's a loaded question, Greg. No, first of all, sense of humor is what has managed to keep me afloat, along with my faith in God. I'll put that right out there up front. You know, if it wasn't for that, if surrendering it to a power greater than myself, my sanity would never have been restored. And I think a lot of people know what that step is in so many organizations like AA and things. But regardless, getting back to the question, the wake-up call, I had also anosognosia. So I was battling with denial on a constant basis. Not to mention the euphoria that I was getting from the mania was so addictive that I became an adrenaline junkie for danger. So along with the complex PTSD, which was developed due to sexual assaults, multiple assaults, due to the times when I would get manic and I would get exploited or taken advantage of, unfortunately, because you become very trusting when you have the form that I'm like a happy drunk. I regress. I oftentimes regress to my younger years. I think I'm 21 and everybody's my friend. And it just becomes a very dangerous situation, Greg. And unfortunately, I reached a point where I almost got killed by someone. And I survived. And I'm a survivor and a thriver, as far as I'm concerned. And it's been 6 years now since my last reality check. And hopefully, not hopefully, it is my last reality check. That's what I call it. So without losing my train of thought here, I guess what happened was I came to terms with complex PTSD being the primary reason why I had developed this creative way to protect myself through bipolar disorder. And I'm not saying I had control over what I developed. I could have developed anything, but my mind chose that type of disorder. And that's why I have creative things and thoughts that come to me when I'm manic. I don't think I've answered all of your questions.
I know that you found some things along the way that do work for you.
Oh, yes.
Helping to manage your bipolar disorder. One that you mentioned was the NAMI Connection Recovery Support Group. Is there anything else that you would point to, or you could say more about the connection group that like has turned out to be very helpful in managing bipolar and complex PTSD?
There's no doubt that if it wasn't, oh gosh, without connections, boy, there's no words to. I'm actually looking at my recent NAMI Connection State Trainer certificate. I am now a trainer for the state of Colorado. I hope for other states as well, if I can lend a hand. But going back to when I was just someone who's desperately looking for help. I also got involved with other organizations, faith-based organizations, but the churches are so not in tune with what they need. And I'm hoping, without putting a spin-off here, FaithNet, I hope NAMI's FaithNet will be able to develop a lifeline for the churches so they can help their congregation, so they can help their flock, so their priests and their ministers and their pastors know how to help the people that are coming into their churches desperate to unite God with their doctors and doctors with their God, to find a way to find healing on all levels. With that said, I actually started with Connections. Wow, it's got to be so, well, it had to be 8 years now. I started off with just a few people that were in the group, and then it grew and grew and grew, and then I became a volunteer. But what really helped me was medication, and accepting the fact that I was going to have to add an extra pill to my cocktail. And I don't think people understand how difficult it is to take a pill and realize if you don't, you could lose your life as you know it. It's terrifying, because what would happen if I got in trouble with the law? And again, another sidetrack for just a second, if you don't mind. I feel that, you know, the movement of Frontline with NAMI right now, the movement to help our frontline people that are out there trying to help those of us like myself or family members like you, Greg, that are trying to help your loved ones. So there's a lot of stuff going on with that. But for me personally, what has helped me is the self-care that I have used. Stress is the #1 thing that will trigger TD and make it more severe. And I am a type A person. I have high energy. I'm very out there. My personality, it's so nice to finally figure out what my personality is and what is my condition. But somehow they kind of work with each other in a beautiful way if I allow it. It's a dance. Same with TD. I mean, I've had to resort to getting to the point where I had to get shots of Botox in my face, in here, in my temples, in my skull, because the muscles were compensating in the wrong way. They were not releasing because they were doing the opposite of what they should be doing. And that's what TD does. It screws your system. And I'm not a doctor, Greg. I'm not a therapist or a psychiatrist. I'm just someone who said, I need help here. My face would contort to the point where I didn't even look like myself anymore.
That's,
So,
yeah, wow. That's such interesting insight. You know, the way you shared around the impact that stress can have on TD symptoms, and then, you know, a treatment that you sought out that made, you know, in your, the way you saw it was it made TD more manageable, in the sense that, like you mentioned, Botox, like, so it helped to manage some of the involuntary movements associated with TD, and it worked for you. But can you talk to me more about like what you see as being effective and comprehensive TD treatment? What does that look like in, you know, today's day and age?
I think self-care, we all know by now that that's hit the mainstream. I think they're making movies called self-care, you know, part 1, 2, and 3. For me, Greg, actually, yoga, I'll go right to it. Yoga, meditation, self-soothing techniques like tapping on the body, centering, bringing yourself to a center, filling your mind with thoughts that can release negative energy, negative thought patterns, doing opposite, you know, DBT techniques, whatever it's going to take. Even, you know, spraying myself with rose water. I know it sounds kind of weird, but it brings me back to, I have more control than I think I do. And it's about the breath. really. It's about getting in touch with your inner self, as far as I'm concerned. That's how I've done it. And it's brought me back to getting more control over my body. Just like I think about Michael J. Fox. I don't know why, but Michael J. Fox to me is so inspiring. I remember when he first came out and he was shaking and he was a mess, but slowly he found ways to control some of that to some degree. And he's been able to be a spokesman for such incredible things. And I guess that's why I'm here. I hope I can do that here for TD.
Absolutely, yeah. Well, so some of those self-management, practices that you mentioned, I imagine could be helpful for anyone listening who believes that they or their loved one may have TD. It's worth mentioning here as well, and I don't know if this is something that you can speak to or not, that there are FDA approved medications, I believe, too, for the treatment of TD, and those have only been on the market for a few years. So I think that there's still a lack of knowledge and awareness about the availability of such medications. Although more and more we're seeing efforts being made to let people know that that's out there. And in fact, you can turn on the TV, and chances are, if you're watching in prime time, there's probably going to be a TD medication commercial. So I hopefully that's, getting the word out. In some of the other conversations I've had, I've learned that that insurers are increasingly being willing to pay for TD medication, which is encouraging. Medicaid in Texas has the TD medications as preferred products. And the manufacturers, from what I understand, have some prescription assistance programs set up to help people afford their medications. So curious for you, is that something that you've looked into? Is that something that you and your doctor have looked into at all?
Oh, absolutely. She took charge of TD, not my TD, but my form of TD. And we talked about the different options of what kind of medications she could add to my regimen that would not profoundly affect me, like add more side effects. Like, I already was dealing with the standard, side effects that come with the medications that I'm on. So being with my background in pharmaceutical sales and having the training that I did, I understood the magic and the power of the medications, of the right medications. And when you're dealing, if there's one where I can speak out to anyone who's watching or will watch this video or any part of the video, I just want to say, have faith by advocating for yourself. You have a voice that you can use for yourself. And for me, it was about accepting the fact that one extra pill was going to prevent me from having to backslide constantly in my compliance with my medications, with my doctors, with my psychiatrist, my therapist, my employer even. I have a responsibility to myself, and that's where I am. And if it takes an extra pill, I am willing to do that because I have a doctor who will make the adjustments she needs. And that's the other thing. Our doctors need help to be educated of these things. And I hope that this is just another possibility for us, Greg.
Absolutely. Yeah, well said. Very powerful message. Is there any, just in conclusion here, is there any other advice or bottom line message that you would like to share with anyone who may be watching who is an individual or family member who that may be impacted by TD?
Wow. For the person who wonders why they're holding onto the strap of a train, I think it was the commercial that you're talking about, and this woman was trying her best to keep herself, steady. I think there may be another commercial, who knows? But regardless, if you're that kind of person like I was, where you're like, what am I going to do? What is this? You may not even know what it is. Maybe you have a doctor who just they're so concerned about getting you back to a level of stability that TD is the last thing on their mind unless you bring it up. for yourself. And I guess advocating, educating, and family members supporting our family, getting that support for themselves and understanding TD. I would say don't ever give up on your loved ones, and out there fighting the good fight of, you know, stigma, and knowing that there's a way to stop that just by being compliant and making choices that will give you the life that you're worth living.
Wow, beautiful. Thank you for those words. And I do hope that anyone watching knows that we are here for them, that resources are available, that recovery is possible. They can reach out to NAMI Texas, to NAMI Colorado, to their local NAMI anywhere across the country, and get, at the very least, get pointed in the right direction for whatever resources they may be seeking or that they may need. So thank you, Athena, so much for doing this. This is really, really powerful. I've been, you know, looking forward to this for a long time. I've had a lot of opportunities personally to speak with providers, mostly psychiatrists, also psychiatric pharmacists, who have treated people with TD before. And I love those conversations. Like, those bring a real scientific, you know, perspective to these conversations. But, you know, you bring something very unique, and that is lived experience. And so to hear it directly from someone who has been impacted is powerful, it's informative, and I think it's critical, it's essential to our efforts to raise TD awareness. So thank you for being willing to share and being part of advocating for people who have been through similar experiences. It's an amazing thing, and I admire you for that.
Thanks, Greg. Thank you for what you're doing too here in Texas, or I feel like I'm in Texas.
Not far.
Virtually. Anyway, thank you.
My pleasure. Take care. This is called Texas TD Talks, and I'm honored to be interviewing Dr. Alejandro Natividad. Dr. Natividad, thank you for doing this interview. I'm told that you're a board-certified psychiatrist working in Amarillo, Texas. Would you tell me about your training in psychiatry, the settings that you've worked in, and what your current practice looks like?
Good morning, Greg. Thanks for having me. I completed my residency training in psychiatry in 1992 from University of Missouri, Columbia, where I stayed for 2 years as an assistant professor and moved to Amarillo in 1994 to begin private practice. And I served as a medical director for Pavilion, which is the biggest psychiatric hospital in Amarillo, for 22 years. And was also a clinical psychiatrist for Texas Manhattan Center, which is the main community mental health center since 1994 and up to the present time.
Fantastic. Well, you've had a long and distinguished career in psychology, in psychiatry, and I really appreciate you doing this interview. We are going to be doing our world premiere of the Texas TD Talks video series on May 2nd in Amarillo. So I hope you'll be able to join us for that. And we're really honored that,
Sure.
You've chosen to be interviewed. So I'm curious about what drew you to work in the field of mental health.
So, you know, Greg, my journey to mental health was accidental and a lot of twists and turns. ironically, psychiatry was one of the subjects I was not good at in medical school. It was rather complex, at times not an exact science or discipline to comprehend. Well, along the way, I was fortunate to be accepted as an intern at Fulton State Hospital in Missouri, where we have the most severe and criminally insane patients that were incarcerated. Intriguing and complex. You know, it makes the Silence of the Lamb in the movie a walk in the park in comparison. This piqued my interest and triggered me to apply at the University of Missouri, and the rest is history.
Can you tell me a little bit about like a historical perspective on tardive dyskinesia? How has it come into play for your patients over the years?
So actually, Greg, when I was in training in medical school and residency in the 1980s, the dictum then to treat TD was simply do not get TD because there's no treatment known at that time. It was simply a hopeless disorder and the patients suffer as the symptoms are progressive. So we as specialists invented treatments to the best that we can, and we utilize medications such as benztropine and Artane, which are a class of medications that are anticholinergics. The problem is some of these drugs cause some side effects. Artane in particular causes some buzzing sensations and a feeling of high, and so patients tend to abuse them, right? In addition, some of those medications can cause dryness, blurred vision, weight gain, and memory problem. In addition to that, we have other add-on medications like propranolol or beta blockers, and even Ativan, again, which is abusable. So it was problematic. None of these drugs actually treat, they're just like a supplement to alleviate some of the symptoms.
And how would you characterize a typical life experience for someone with tardive dyskinesia? What kind of impact have you seen it have on patients' lives?
Yeah. So, Greg, you know, the natural course of TD is sometimes it begins with just mild tremors of your hands or fingers, or twitchings around your mouth or eyes, and they're intermittent until they become more frequent and daily, progressing to bigger muscles like the hands, the limbs, the neck, jerks, and even your truncal muscles. At some point, some of these patients, because they're exposed to antipsychotic agents, right? The symptoms become more progressive and disabling because some of them can no longer write or hold a cup of coffee, or even their ambulation suffer. So that is the physical aspects of that. But the psychological and social disabilities associated is that, as you know, mental illness in itself is already a challenging condition for these patients. And then you add on the physical appearances and abnormal movements. So they tend to shy away being in public because there are some stares and looks that they get for the way they behave. They feel abnormal when they relate to somebody else. So they're in some way physically and socially disabled as a result.
Yeah, before a person gets access to the right treatment, it can clearly be a very disabling condition, and it can cause a lot of social isolation. It can make it hard to hold down a job or engage in a school setting. So, you know, that can be very challenging for individuals and families, but I think there is hope, and we'll talk about sort of what can improve a person's life when they may be experiencing TD. And so with that, you know, with that thought in mind, you know, let's say a family member or an individual sees this video and becomes educated on TD, and they believe that they or their loved one may be personally impacted by TD. What advice as a psychiatrist would you give them in that case?
Greg, thanks for asking me that. The best part is TD, suffering from TD is already optional. We have 2 drugs now that are super effective in not only alleviating or decreasing the symptoms, some of them even go in remission. And so what we need to do now is to increase the awareness from clinical providers and the consumers alike, so that there is more engagement and request to get the right treatment to you. Do you know, in the United States, currently there's about 500 to 600,000 TD patients. Unfortunately, despite these effective treatments available now, about 10 to 15% get treatment. So if you talk about, say, 500,000, you only talk about 50,000. So we're very early in the inning here, just scratching the surface. So as we make the even the primary care providers, because they see some of this, and even nurse practitioners who are now effective providers for psychiatry, clinical awareness that these drugs are available should be sought off as much as possible. And if the consumer cannot afford these 2 drug companies, like the Ingressa is one, and then the Austedo, they have their own patient assistance program. And so that, so being able to not afford is no longer a friction to get correct treatment.
That's great information. You know, that is striking that so few people with TD are actually accessing the treatment that they need for it. But it sounds like things are heading in the right direction, in that insurance companies are increasingly paying for the treatment, and for those who lack access to insurance, there are prescription assistance programs that are available through both TD medication manufacturers. So it's important for people to be aware of that. And you know, another point that you made that I think is worth, you know, underscoring is just raising awareness about TD and raising knowledge about what it looks like and how it can be treated is so important. And, you know, not just in the psychiatry community, but across all mental health provider types, and across the entire healthcare system. And among we want caregivers and family members to also be educated about TD, so that, you know, we're linking people up who are impacted with the treatments that are available to them.
Absolutely, Greg.
Hopefully, you know, this Texas TD Talks video series and the world premiere screening event that we're doing in Amarillo, you know, plays a role in closing that knowledge gap about TD and the treatments that are out there. Just last question for you before we wrap up. Is there any bottom line message that you would like to share for anyone listening to this interview who may be impacted by TD or have a loved one who is impacted?
So let me, if I may, Greg, let me share you a remarkable story that today is surprising to me. I have this patient, call him Eric. I began to see this guy probably 2001, right? Schizophrenic, very disabled, and he has been exposed to chronic neuroleptics from Haldol to the newest one. Unfortunately, because of the cumulative exposure, he developed severe TD, and he could no longer walk without falling. That's all over the place. So anyhow, what happened was last year, or I think 2 years ago, I started the guy on Ingressa, or one of the TD medications. And today, or about roughly 30 days after that, up to this time, the patient is symptom-free. there is not a single symptom of any abnormal motor movement. And in fact, I saw him 2 weeks ago with his brother. And they said like this, Dr. Natividad, again, thank you very much for changing my brother's life. He's not scared to be around people. And we have a problem. What is that? Well, we would like to move to Oklahoma, but we can't because you won't move to Oklahoma with us. So therefore, I said, you know what? Thank you for your kind words, but there are a lot of good people in Oklahoma who could provide the same medication. As long as they continue to do this, you should be done okay. So the message is this. Regardless of how severe the symptom is, the chance of significant recovery is very high up to remission. And clinicians should not give up. There is a road to recovery. And the amazing part is from a physical and social disability to becoming normal is one of the greatest rewards that a clinician can ever have. So I think if we can understand that story as an example and an inspiration to everyone, TD is no longer a disorder of suffering. TD can be normalized and life goes on.
Oh, that's so powerful. Yeah, thank you. Thank you for sharing that. I think that's such an important message of hope for anyone who may be listening. Well, with that, thank you again for doing this interview. And if anyone is watching and has any questions about TD, please feel free to reach out to NAMI Texas, and we'll be happy to share information with you that may be helpful. Thanks again, and take care, Dr. Natividad.
Thank you, Greg.